Dr. Gibbs, in our sponge accounting curriculum, we know after the nurses they're at a final count and they're missing a sponge and they've gone through their incorrect count checklist, followed all the steps, and they cannot find that sponge. That's when we bring in our defenders from radiology to help us shoot images to see if that sponge is in the patient. Mm-hmm. Can you talk about some of the critical components that the radiology provider must follow, because they're part of that team as soon as they step into the procedural area and they have a defined role in this practice related to sponge management?
Sure. So in the incorrect count checklist, what we point out is that if you have failed in the OR to identify the sponge, or in the procedure room, now you need to bring in that other stakeholder, which, as you mentioned, our critical defender, which is our radiology colleagues. And that includes our radiology technologists as well as the radiologist who may be sitting someplace else looking at the now very common digital images. And the important thing is the communication which has to happen. The nurse needs to call or communicate to get the radiology technologist in the OR. And as soon as that radiology technologist steps in the operating room, they have to recognize that they're part of the team. They're part of our OR team. And their job is to help us find the missing sponge, be that a lap pad or a ray tech. Because if we knew where the sponge was, we wouldn't need them to come and help us find it. So it's important that the radiology technologists take advantage of our missing surgical item guidelines, which we've provided as part of this multi-stakeholder effort, which Tenet has incorporated into the teaching and training of radiology technologists so that they know what to do when they're coming to the operating room to, say, have a missing surgical item abdomen. And as an example, the most important thing there is to have upper and lower margins and skin fold to skin fold included on that image. Second most important thing is to make sure that we have content experts interpreting those images, and that's radiologists. So even though surgeons could look at a film and see whether or not there was something there, only a radiologist can call an image negative. So we need to get the radiologist to call back into the operating room to talk to the surgeon. We need to get the surgeons to stay in the operating room to receive those calls from our radiology colleagues. And if they need to take additional views, we get that done, because our goal is to make sure that we get the sponge out, or we find the sponge before the patient leaves the operating room. And lastly, we understand that Tenet has done a really great job in trying to improve the use of the electronic medical record, rather than relying on picking up the phone and calling and literally playing telephone between the radiology technologist and the radiologist, is to incorporate all of this within your physician order entry menu. And let me just point out there's one other element in all of this, and that's that communication strategy again, that strangely enough, people all around the country call their sponges different things. Mm-hmm. So in Oregon, what is a ray tech for some is an RP. In Alabama, what's a little Kittner is a cottonoid or a pusher. So the pusher to you is a peanut to somebody else. And it's important, especially when we're communicating with our radiology colleagues, that if we say we're missing a peanut, they know that it's not the peanut that's made by Planters, it's the peanut that has a little ring for a radio opaque marker. So we need to start the practice with radiology champions and consider them our teammates, and make sure we have both strong communication and practices in working with them to help make sure that there's nothing left behind.